My name is Nancy Chobin. I'm the president of Sterile Processing University, and I'm here to present a program on understanding the updated ST91 AAMI Endoscope document. We're going to discuss the updated recommendations for processing flexible GI endoscopes. We're going to review and discuss how to comply with the changes and discuss the implementation strategies. I do want to go over some definitions or wording that AAMI uses, which they've made for clarification. In an AAMI document, they only use the word must when it's unavoidable and usually those mandated by a government regulation. So must would apply to OSHA because that's a federal regulation. When they use the word shall, that means that these requirements are strictly to be followed to conform to the recommended practice. In other words, you really should be doing it. Should indicates that among several possibilities, one is recommended as the most suitable without mentioning or excluding others. May indicates that a course of action is permissible within the limits of the recommended practice, and can means a statement of possibility and capability. So must, shall, and should are the three that we're most concerned about. Now, this document covers the processing of reusable flexible endoscopes, bronchoscopes, and semi-rigid endoscopes, and those two seem to get forgotten, but they are part of this document. It does not cover rigid endoscopes. They're covered in ST79. And it does not cover TEE or ultrasound probes, and AAMI has a new technical information report being developed for these items. We have a lot of issues with flexible endoscopes. They're very complex devices. They have long, narrow lumens. They have right-angle turns, and they might be heavily contaminated with pathogens, especially when they're used in the GI tract. Endoscopes can transmit infections. Pathogenic microorganisms may be spread from patient to patient, from patients to endoscopy and processing personnel, and from endoscopy and processing personnel to patients. We also know that microbes today can be highly resistant, and personnel and patients can be exposed to chemicals that we use to process the endoscopes, and there can be endoscope damage during use or processing. We also have insufficient processing time. Time is money, and people want things done right away. And there have been several studies that have shown that a majority of people who process endoscopes say that they don't always have sufficient time to do it. Well, when we don't have enough time, where are they going to cut down on the process? On cleaning, which is the worst part you could cut. There's a lack of knowledgeable and skilled personnel and a lack of compliance with established guidelines. Yet we have multiple resources out there. And unfortunately, a lot of them don't say the same thing, which is why AAMI came up with this document. You have SGNA saying one thing, AORN says something else, Multi-Society says something else. Joint Commission found it very confusing as well. AAMI documents are national standards, and that's why they came out with this document. So let's start with processing personnel. I mentioned we have people who are not always trained and competent. Everyone who processes an endoscope needs to have formal training and competency assessments. And that training should include every aspect of processing the endoscope before they're actually assigned to do any of the tasks on their own. It would be the same thing in sterile processing. You wouldn't have someone use a sterilizer unless they've shown a competency assessment. All personnel performing processing of endoscopes should be certified in flexible endoscope processing within 2 years of employment and should maintain that certification throughout their employment. Now, AAMI is not a regulatory agency. They cannot enforce this. They cannot force facilities to have their people get certified. But in a court of law, as someone who does legal consulting, that's what I look for. Did your facility look for the high objective of making sure that everyone processing endoscopes was certified in that specialty? This is not the same certification as sterile processing technician certification. It is specifically dealing with endoscope processing. And there are two certifications that are available that are recognized through AAMI, the Certification Board for Sterile Processing, and Healthcare Sterile Processing Association, formerly ISHM. You want to make sure that training and competency verifications are performed upon initial hire, annually, at designated intervals, or whenever you get a new endoscope model, new processing equipment or products, such as a new chemical. Also, if you get a loaner scope, there was an outbreak of infection in one facility. A loaner scope came in. There was a channel on it that their original scope didn't have, and nobody was cleaning the channel. And next thing you know, there was an outbreak of infection. Now, we say upon initial hire because sometimes you hire someone from someplace else. Don't assume that they know what they're supposed to be doing or that they use the equipment that you have or the chemicals or even the scopes. Oversee their processing activities until competencies have been verified and documented for each task, and include tasks such as point of use treatment through storage of the endoscope and transport to the next point of use. For competency verification, what are we looking at? Well, is there compliance with your policies and procedures and manufacturer's instructions? Do you have compliance with instructions for each manufacturer and type of endoscope process at the facility? Now, if you're lucky, you only have one manufacturer's endoscope. They're all ABC endoscopes. But in some facilities, they have multiple manufacturers and multiple models of scopes. So you need competencies on all of them. You need competencies on staff proficiencies in processing the scopes. An assessment should be performed by personnel with expertise in processing flexible endoscopes. Surveyors are now rejecting competency assessments if the person who performed the assessment did not have expertise in the respective area. So if you have someone who's never processed the scope, they should not be doing the competencies. For policies and procedures, again, you need to monitor compliance with all policies and procedures, and your policies and procedures should be based on AAMI standards. You could add SG&A and AORN if there are things that are not in the AAMI standard, but you need those policies, and then you have to make sure people are following them. Inform the manufacturers and the FDA, if applicable, if the IFU seems unclear or inadequate, or you are unable to be performed due to technical incompatibilities. You are responsible to report any difficulties with processing any equipment, including a scope, because if you're having that problem, it could be a lot of other people are. And when the FDA knows that, they can investigate it and see if a recall needs to be done. So let's start with point of use treatment. Before, we used to call this pre-cleaning, and that gave the impression that this was all that had to be done. Point of use treatment should be performed in the procedure room immediately after completion of the procedure. And that is important to know. The longer those soils remain in that scope, the more difficult they are to remove. This process is important because the point of use is going to moisten, dilute, soften, and remove organic and inorganic soils, and reduces the formation of biofilm. And once they form, they're very difficult to remove. It also ensures that all IFUs are followed, including those of the endoscope manufacturer, the cleaning equipment manufacturer, the cleaning solution manufacturer, and if you're using sponges or wipes, make sure they're cleared by the FDA for point of use treatment, and those can be used. For the physical design, it's preferable to have two separate rooms, one for cleaning, one for high-level disinfection. But that's not always possible. And if you just have one room, you should use strict linear workflow from dirty to clean to high-level disinfection to avoid cross-contamination. After you perform cleaning activities, you should remove all of your personal protective equipment, put on new personal protective equipment, clean and disinfect all the work surfaces because they can be contaminated by your decontam activities. Then begin your clean, high-level disinfection activities. And you should have a designated area for drying the scopes using instrument air prior to use, storage, or in preparation for sterilization. In a one-room design, you usually have limited separation between dirty and clean. In that one-room design, you should install a separating wall or barrier 4 feet above the sink rim between the clean and dirty areas. Or it can go from the countertop to the bottom of the cabinet above, if applicable. In a two-room design, you have a separate decontamination area. You have a separate clean area where high-level disinfection or sterilization occurs. You can use a door or a pass-through window to pass items between the two rooms. Now, we mentioned instrument air. A lot of people are not familiar with it. For years, we used compressed or medical air, and we found out when we were updating ST79 that that's in violation of fire code. So instrument air is a medical gas that falls under the general requirement for medical gases as defined by National Fire Protection Agency 99 Healthcare Facilities Code, is compliant with ANSI quality standard for instrument air. And the reason it's different is instrument air is filtered to 0.01 microns, is free of liquids and hydrocarbon vapors, and dry to a dew point of minus 40 degrees Fahrenheit. This is very, very pure air. And the reason it's recommended is we don't want to recontaminate our scopes or any lumens after we've cleaned them. Now, instrument air can be supplied from a bulk cylinder, bulk containers, or medical air compressors. You can also use HEPA filtered air. You should have a gauge on your unit to control the pressure when drying your scopes, and you need to comply with the scope manufacturer's recommended pressure to avoid damaging the scope. If the pressure is too high, you can damage the sheath on the scope. Endoscope processing sinks. It's amazing to me. I go into facilities and the sinks, you could just about wash your hands in them. You need sinks that are large enough to process scopes without damaging them, at least 16 by 30 inches. If possible, and you're getting a new area, look at height adjustable sinks because that eliminates a lot of back fatigue. Or you can provide footstools for good ergonomics. You must provide or should provide a minimum of 2 sinks. In the first sink, you will do the leak testing and the cleaning, and the separate sink for rinsing and final rinsing. The best practice, though, is to provide 3 sinks: the leak test and clean in the first, rinse in the second, and the final rinse in the third. Always have to talk about hand hygiene. You need a hand hygiene sink in the decontam area, and it must be separate from the sinks used for cleaning and rinsing. You will also need a sink in the clean high-level disinfection area, and even if it's in the same room. And you need a policy for hand hygiene. Emergency eye wash stations. You need an eye wash station in all places where chemicals are used. So in a 2-room design, you will need an eye wash in both rooms. This means in the area where devices are clean versus the area where they're high-level disinfected. There is a standard. ANSI has the minimum performance criteria for eye wash units. It's ANSI Z358. And it says that employees who may be exposed to hazardous materials must be instructed in the location and use of emergency eye washes. Eye wash should be tested weekly, and it has to include the water temperature, which needs to be between 60 to 100 degrees Fahrenheit. That's to prevent damage to eye tissue, and you should document all the testing. When we transport the used scopes, we have to keep the soils moist. We can keep them moist 3 ways. We can pre-treat them with a solution. We can put water, moistened towel over the item, or we can use a humid chamber bag. Any of the 3 are acceptable. When we transport the scopes, we want to make sure that we confine and contain them in a closed container or transport cart. Whatever we use to transport has to be leak-proof, puncture-resistant, large enough to contain all the contents, and labeled with a biohazard legend. It has to be big enough so we can loosely coil the endoscope so we don't damage the fiber optics in it. We shouldn't place accessories in the container because they could damage the scope. And the container has to be cleaned and disinfected after each use. So we can't go out to, a supermarket or a big box store and get one of those clear plastic containers and slap on a biohazard label. You need a container that has been validated for cleaning and decontamination. So make sure your containers have IFUs for that. Transport the scope in a horizontal position that's suspended. If you only have a single dumbwaiter or elevator in your facility to transport both clean and sterile, separate the soiled items and don't put them on the same cart as the clean and sterile. And if you are using a transport cart, they should be covered or enclosed. You have to remember that all items, clean or soiled, should be contained in transport containers and must be labeled either as biohazard or clean or sterile. Separate the scopes from accessories, and you will need a cleaning schedule for your dumbwaiter as well, and who's responsible for it. Now, this is something that is very, very new. It's called the handoff of used scopes. This is the information that the transporter of the scope should be reporting to the processing technician. First, confirm the endoscope was transported correctly. Second, that all accessories and parts are present. Third, the date and time of completion of the use of the scope. 4, the time the point of use treatment was performed, and then a patient identifier. Now, this is important because we need to know the delay from the time the point of use was performed to the time that scope was clean. And in many facilities, there's one person who does everything. They're transporting people, transporting scopes, cleaning the scopes, and delays can be very long. In the processing area, determine if delayed reprocessing protocols are needed, and that has to be checked with the scope instruction for use and follow those instructions. Attire. Attire is exactly the same as any other decontamination area. The problem is in a lot of the endoscopy centers that I go to, they're not wearing all of the PPE they should be wearing. So we know they should have uniforms provided by the facility. They should be changed daily or as needed. Their uniform should be laundered by a healthcare accredited laundry. All head and facial hair except for eyebrows and eyelashes should be completely covered. I don't see that happening. Jewelry and wristwatches should not be worn in the processing area. I don't always see that. Shoes should have non-skid soles, be sturdy enough to prevent injury if an item drops on the foot. And the uniform, remove the uniform before leaving the healthcare facility unless the facilities are connected by an internal walkway. And that's something that surveyors are really looking for. And this is from ST79. A lot of us are going to other campuses and you don't see people changing out of their uniform. PPE also is a challenge in a lot of endoscopy centers. Anyone working in decontam should wear general purpose utility gloves. Now, I don't like that wording because people think it's like the Playtex glove that you get in the supermarket. While they're thick, they do not meet the standard. That glove has to prevent contact with the contaminated water. It should be designated as a decontamination glove. It should be tightly fitted at the wrist, although there's longer gloves available for endoscopy, like you see in the photo here, that come up just below the elbow. Exam gloves should not be used for decontamination because they do not provide enough protection. But decontamination duties, the highest level gown should be worn, which is a level 4. Some people wear the yellow isolation gowns. All of these gowns are rated now. A regular isolation gown that looks like gauze, I actually put some water on it, and within 10 minutes, the water soaked through it. So even isolation gowns are supposed to be rated today. Level 4 is what you should be wearing. You should have a fluid-resistant mask, liquid-resistant shoe covers, and eye protection. The personal protective equipment for your eyes should protect them from splash, and that includes goggles, full-length face shields, or other devices that prevent exposure and splash from all angles. If you're wearing the mask with the visor, that is not sufficient. It will not protect you from splashes from above. So you must have a fluid-resistant mask and a face shield. If noise levels exceed the OSHA permissible levels for the designated time duration, hearing protection should be available. And this is in terms of using pressurized air. If gloves become damaged or torn, you should remove them, thoroughly wash your hands, and then put on new gloves. Now, I did some research on that OSHA noise level. OSHA requires employers to implement a hearing conservation program when noise exposure is at or above 85 decibels, averaged over 8 hours, or a time-weighted average. Hearing conservation programs strive to prevent initial occupational hearing loss, preserve and protect remaining hearing, and equip workers with the knowledge and hearing protection devices necessary to guard themselves. NIOSH, or the National Institute for Occupational Safety and Health, has a sound level meter app, and it's one tool available to the public to download on a mobile iOS device that measures sound levels in the workplace and provides noise exposure parameters to help reduce occupational noise-induced hearing loss. And I gave you the website to get more information. So this would be due to the instrument air that you're using. Now, for PPE, you're going to perform hand hygiene immediately after you remove it. It should be changed between performing decontam and handling high-level disinfectant endoscopes. And this is sometimes an issue when there's a one-room design, when someone's going back and forth. Before leaving the cleaning area, employees should remove all their protective attire, being careful not to contaminate the clothing beneath their skin, and perform hand hygiene. You're going to need a container for donning and doffing PPE, preferably at the entrance to the processing area, so whoever is coming in doesn't have to walk through the area to put on their PPE. Leak testing. This is one of the most important parts of the process because any breach in the integrity of the sheath of the scope or the surface can lead to contamination of the endoscope. This can cause major damage to the scope, like you see here. And ST91 has information on the different methods of leak testing. When you do leak testing, you want to put on your PPE and perform the leak testing as soon as possible after the endoscope arrives in the processing area. You have to follow the instructions for use for the specific leak test that's being performed. But you also have to follow the endoscope manufacturer's written instructions for their criteria of the leak testing protocol, including quality controls you should be doing. Flexible endoscopes that cannot be leak tested should not be used. And manual handheld leak testers and leak tester tubing should be inspected for damage, leakage, and pressure output. Dry leak testing does not require immersion of the endoscope, but it's more subjective and more time-consuming than wet testing. Even a slight loss of pressure can identify a small leak, but if you follow the instructions, you will not have a problem. Powered leak testers are preferable to manual leak testers. They provide a continuous flow of air that prevents fluid from invading the endoscope. There's new dry leak testers on the market that can test 2 scopes at the same time. You do not have to immerse them. You hook them up to the unit, and the test results can be printed and can be downloaded to a computer. There's no need to observe for air bubbles or angulate the distal tip. So manufacturers are coming out with better and more objective ways to test the scopes. Testing your leak tester. You need to test if your leak tester is working properly. Who knew? Each type of leak tester should be tested each day the endoscopes are used. Make sure your leak testers are functioning correctly. Follow the manufacturer's instructions for testing each type of leak tester, whether it be manual or mechanical, that's used in your facility, and document the test results for each leak tester in use. So you're going to have 2 records, one on testing your leak tester and one on the actual leak test results. You should have a large counter or work surface so that you can leak test your scope, and it's minimally coiled. Remember, the more tightly you coil it, the more possibility of damage to the fiber optics. Wet leak testing requires a clean sink with clean water without detergent. If you have detergent, you're going to get bubbles, and it's going to interfere with your test results. Clean and decontaminate your leak testers according to the instructions from the manufacturer. Follow the manufacturer's instructions for leak testing. And for wet leak testing, make sure the scope is insulated first to prevent fluids from entering the scope if there is damage. So you're going to pressurize the scope. And once you do that, if it does have a breach when you put it into the solution, the pressure is not going to allow the water to get in and make that damage worse. Follow the scope's instructions for recommended time for pressurization to make sure you get an accurate test. Again, clean water, no detergent. Document the leak test results for every scope tested and keep those records. If you're using an automated leak tester, place it on a calibration schedule and retain those records. And if you are performing wet leak testing, the minimum observation time is 60 seconds, and I don't see that happening. What happens when a leak test fails? 1, you're going to remove it from service. 2, you're going to send it for repair, or you're going to replace it as needed. And you're going to refer to the endoscope manufacturer's instructions for guidance, because you can't send back a scope that you haven't been able to clean or disinfect. So your manufacturer will tell you what to do when you send it back to protect their workers from having an exposure. Water quality. Oh, we're hearing so much about this now, and it does have a big impact on all stages of endoscope processing. You can have utility or tap water or critical treated water, such as reverse osmosis, sterile, distilled, or deionized water. You must follow the water quality recommended in the manufacturer's instruction for each stage of endoscope processing. Your water for cleaning may be different from the water in the initial rinse, which could be different from the water quality in the final rinse. Review the manufacturer's written instructions for all equipment and supplies used, including endoscopes and accessories, your automated endoscope reprocessor, and chemicals used. And use of the correct water quality helps to prolong the life of the device, facilitates their effective functioning, and reduces the risk of medical device contamination. Monitor and control the water supply quality to endoscope processing sinks and equipment. Any major repair or changes to the water utility system should be treated as a major repair to the endoscope processing equipment, such as your AERs. And your equipment should be requalified before use if you have a major repair to your water. Water quality evaluation should be conducted when there is installation of water-consuming equipment or the water supply. After repairs to water-consuming equipment or the water supply, so say you have a water main break outside your facility. After modification of water routing infrastructure and during investigation of endoscope processing cycle failures, and comply with the new ST108 water for the reprocessing of medical devices that was just published from AAMI. Environmental cleaning, you should have, this is copied from the amendment in ST79 to ensure that we have a clean environment wherever processing is taking place. And you should have a committee that's going to define the roles and responsibilities, who cleans what and when. Because if you don't define it and you don't assign it, it's not going to happen. And they should know the cleaning chemicals, the materials, the tools, and what equipment is going to be used, the cleaning frequencies for high-touch objects or surfaces, cleaning frequencies for all other surfaces, such as your storage shelves and storage cabinets, determine terminal cleaning frequency for endoscope processing areas, which should be minimally daily if the space is used, and more often if you have a spill. Define where food beverages are permitted outside of the endoscopy processing area, and most importantly, maintain a log for the cleaning of the area and for the endoscope storage cabinet. So environmental cleaning is very important, and you have to make sure that you're compliant with not only 91, but in your other areas of your department as well. Manual cleaning of scopes. Make sure that cleaning is initiated in the time frame prescribed in the manufacturer's IFU. So scope manufacturer will tell you how much time between the point of use and the time that cleaning has to be initiated. If they don't give you a time frame, manual cleaning should be started within 1 hour of point of use treatment, or is determined by the facility based on their own documented risk assessment. I would tell you not to wait more than an hour. That's just my opinion. Detachable parts and valves. These are concerned. You should keep the valves and caps together with the endoscope as a set, or tracking the individual valve or cap to the patient and the procedure. This helps in the event of an outbreak of infection, because it could be the valve or cap was part of the problem. Now, you can use single-use biopsy port caps and single-use valves, which a lot of people have done. You can sterilize reusable valves and caps using steam sterilization if it's in the IFU, or they can be high-level disinfected if it's in the IFU. But if you use the reusable, they need to be kept with the scope, and there's many devices on the market that will help you do that. When you do cleaning of the scope, all cloths used to clean or dry scope should be non-linting. Cloths or sponges should not be reused. Brushes, follow the endoscope manufacturer's written instruction for the type of brush to be used. Use cleaning brushes that are either single-use and disposed of after cleaning one scope, which is preferred, or reusable and cleaned, high-level disinfected, or sterilized after each use, according to the manufacturer's written instructions. So those are your two choices. For water, we usually use an enzymatic detergent, and they usually have a temperature range. Some of them do not. Always check the IFU. If you do have a temperature range, make sure you have a thermometer probe in the solution, that you're not exceeding the temperature. Any probes that you're using, calibration may be required, and if it's not required, the probe should be replaced at the end of their useful life. If an automated flushing device is used, you have to comply with all of the instructions for use for that device. Clean and disinfect the connecting tubing and equipment according to the IFU, and document the process. Remember, do what you document what you do. Any quality assurance testing that's recommended by the manufacturer, like the daily volume verification, should be performed and documented. After cleaning and rinsing, inspect the scope, and if using disposable tubing on your unit, change it as recommended. If any soils are noted, repeat the cleaning process until oils, soils, and residue is removed. If the scope is exposed to any synthetic lipids, radiographic medium, simethicone, or certain patient medications such as fish oil, or used in procedures where the patient had a poor prep or bloody procedures, these scopes will probably or might require additional cleaning. At the end of cleaning, rinsing, purge all channels with instrument air or filtered air from a flushing pump at the pressure and time recommended by the scope manufacturer's instructions. Now, simethicone is used quite a bit in endoscopy, and the endoscopists like it because it decreases the symptoms of excess gas and reduces air bubbles, and will actually improve visualization of the mucosa in the colon. However, simethicone fosters biofilm development. We're trying to get rid of them, not have them grow. This then makes the biofilm difficult or impossible to remove. And recent studies have shown that even when used at very low concentrations, simethicone persists in endoscope lumens after reprocessing. And this is a photo from ST91 showing some simethicone inside of a scope after it was processed. When you clean, minimally remove your glove. After cleaning, minimally remove the gloves and perform hand hygiene before you inspect the scope. Sinks should be cleaned, disinfected, and rinsed between uses. You should use a disinfectant approved by a multidisciplinary team, and according to the disinfectant and sink IFUs. I've never seen a sink IFUs with recommendation, although they might tell you not to use bleach because it'll really harm your stainless steel, but you do want to disinfect your sinks. Now, automated endoscope reprocessors, or AERs. Some of them have cycles that are validated for cleaning. Now, AAMI says that an automated cleaning cycle does not replace the point-of-use treatment. That has to be done regardless of how the scope is going to be processed. And most AER cleaning cycles are not intended to replace manual cleaning of endoscopes prior to placing them in the AER. Now, I know some people have purchased AERs that have a clearance for manual cleaning. If you do, or considering purchasing one, AAMI recommends that you look to make sure it has a validated and FDA-cleared automated cleaning cycle. And then you might want to get your multidisciplinary team together to conduct a risk assessment about not doing the manual cleaning. And there is a sample in Section 13 of ST91. You should consult the AER manufacturer for their validated data concerning the cleaning capability and FDA 510K claims. Verify that they meet or exceed current cleaning requirements set forth by the FDA. Now, when it comes to duodenoscopes, they always have to be manually cleaned, irregardless, and that's from the FDA ruling. It says that the AER cleaning cycle should only be used as a supplement to thorough manual cleaning according to duodenoscope manufacturer's instructions, and that's from 2018. AAMI says that manual cleaning can be used in conjunction with automated cleaning. You have another advantage if you're going to be testing the cleaning efficacy of your scopes. If you clean the scope first, and you could then test it before you put it in the AER. So there is an advantage to the manual cleaning. Cleaning verification and inspection includes visual inspection and cleaning verification tests, and this can include the use of a borescope. Again, from a legal perspective, I think the borescope is the best thing that can happen because it'll take a picture and it's a documented record of what went on inside of that scope. Remember, cleaning effectiveness is going to look for soils, whereas borescope will not only look for soils, but it'll also look for objects. Cleaning verification helps to verify that the desired soil removal was achieved, and the scope can then proceed to high-level disinfection or sterilization. Endoscope should be processed at each stage of the processing cycle, and the FDA recommends that you have lighted magnification of 5 to 10 times in order to inspect them. Now, the 10 times is highly recommended by the FDA for ERCP scopes because of the elevator channel. So if you use both, you can certainly just have a 10 times magnification and use them for oil. Borescope inspection. An endoscope that appears clean can harbor debris that cannot be seen without magnification. They enter the lumen and allow for improved visual inspection. They can be used periodically at a frequency determined by the facility. Make sure the endoscope is dry prior to inspecting it. And if it's used on a scope that was already processed, you do have to process the scope again, which is why, in my opinion, the borescope should be in the decontam area. And if a scope repeatedly fails the cleaning verification, you may need to inspect it with a borescope before sending it for repair. And here's some examples from AAMI ST91. This is some fluid that was found in a quote-unquote dry endoscope. And of course, fluid is very, very dangerous because of the ability for Pseudomonas and other microorganisms to grow. And this was debris. I mean, just look at all of this inside of a channel of a scope. Pretty nasty. Cleaning verification testing. Before performing cleaning verification and inspection, you're going to change your gloves and check that you don't have any soil on your gown and PPE. High-risk endoscopes, including duodenoscopes, linear ultrasound endoscopes, bronchoscopes, endobronchial ultrasound endoscopes, ureteroscopes, cystoscopes, all should be tested for cleaning verification after each use. Now, we're very concerned about the flexible scopes, but people forget that this document also includes semi-rigid operative scopes, and they're supposed to be tested after each use as well, and it's not being done. So you need to go back and make sure that you're doing that. Test non-high-risk flexible endoscopes for cleanliness after manual cleaning using your cleaning verification test when new endoscopes are purchased and at regular intervals. Now, they put the frequency based on the number of procedures performed. I have to tell you that, in my opinion, Why would you proceed with high-level disinfection or sterilization of a scope if you weren't sure that it was clean? In my opinion, we should be testing every single scope. That's the standard of care that I would want for a scope used on me. But this is something you get your committee together, your multidisciplinary team, and come up with a schedule. When establishing a schedule for cleaning verification, consider the endoscope type, the technician's competency, the procedural characteristics such as the duration, complexity, and heavy soiling, or delayed reprocessing. Some of you have carts that go around your facility where they'll bring the endoscopes to the emergency room or ICU, and you know they're not getting point-of-use treatment. You know that they could be sitting up there for hours and hours and hours. What we did in our facility when I was there was we would clean the scope according to the IFU, and then we would do cleaning verification. And if it failed, we cleaned it again and did cleaning verification again. And we did that until the scope came out clean. But follow your IFU in your endoscope manufacturer's instructions what to do when a cleaning test fails. Now, understand the FDA has not reviewed the effectiveness of cleaning verification tests. Manufacturers of cleaning verification assays develop their own methods and criteria for assessing the effectiveness of their products. And these tests are used to verify the ability of a cleaning process to remove or reduce to an acceptable level the clinical soil so that the subsequent disinfection or sterilization process can be effective. So it is important to do them. Visual inspection alone is not enough. Cleaning effectiveness tests can measure the level of organic soil on the clean scope more objectively and is a more sensitive test. They quickly verify that adequate cleaning has been performed. Your quality assurance program should include ways to verify that the cleaning equipment is working properly and that the cleaning process is effective. There is an Annex F in ST91 that has a lot of information on cleaning effectiveness tests and quality control programs. Now, for high-level disinfection and sterilization, what brought us to sterilization with the flexible scopes was a revision or updating of the Spaulding classification, which was initially developed by Dr. Earl Spaulding in 1952. And he said that critical devices are instruments or objects that are introduced directly into the human body, either into or in contact with the bloodstream or other normally sterile areas of the body, and products with sterile fluid pathways. That includes surgical instruments, rigid scopes, and operative scopes. These items present a high degree of risk of transmission of infection if they're contaminated and therefore must be sterile at the time of use. Semi-critical devices are instruments or objects that contact intact mucous membranes or non-intact skin of the patient during use, but do not usually penetrate the blood barrier or other normally sterile areas of the body. This would include flexible and rigid fiber optic endoscopes, endotracheal and aspirator tubes, bronchoscopes, laryngoscopes, respiratory therapy equipment, cystoscopes, vaginal specula, and urinary catheters. Semi-critical devices should be sterilized if possible. However, if sterilization is not feasible, the device at a minimum must be subjected to high-level disinfection. Now, there are many types and methods available for disinfecting and sterilizing flexible endoscopes, and you could find that in Annex I of ST91. You should refer to the medical device manufacturer's instruction and the intended use of the device for the chemicals that are validated for its use. Make sure the method is cleared by the FDA for use in healthcare facilities, and the FDA website does have a listing of all chemicals that are cleared by the FDA. And all flexible endoscopes that are introduced directly into the bloodstream or that contact normally sterile tissue or body space during use are considered critical and shall be sterilized. High-level disinfection, it therefore is the minimum level of processing for semi-critical endoscopes. High-level disinfection, as you know, is a process that kills all microorganisms in or on an instrument, except for large numbers of bacterial spores. A disinfectant is defined by the FDA as a sterilant used for a shorter contact time than liquid chemical sterilization to achieve a 6-log kill of an appropriate mycobacterium species. High-level disinfection and liquid chemical sterilization can be achieved manually or mechanically. But manual high-level disinfection and liquid chemical sterilization of endoscopes is not recommended due to the variability and inconsistency in the personnel responsible for the process. So they're really pushing us away from this system. Whenever we do something manually, there always can be variation. We have variation, we can get into trouble. Liquid chemical sterilization. This can be used to process semi-critical and critical heat-sensitive endoscopes. It's different than thermal and gas vapor, low-temperature sterilization, and it can achieve a 6-log kill of the appropriate bacterial spore shown most resistant to the process in a full cycle. But the FDA recommends that liquid chemical sterilization be used for heat-sensitive critical medical devices only when terminal sterilization methods are not feasible or not available. So again, they're pushing us over to sterilization. Treatment with liquid chemical sterilants may not necessarily ensure the same sterility assurance as terminal sterilization using thermal or gas vapor low temperature sterilization methods. And that's from Dr. Rutala and Weber. That's because the devices are not wrapped during processing. It may not be contained adequately after processing in a liquid chemical sterilant, and there's no assured way to maintain sterility after the devices are processed. High-level disinfection and liquid chemical sterilization. There are several automated processes. There's the automated endoscope reprocessor. There's endoscope washer disinfectors. And this equipment is designed to deliver the liquid chemical sterilant or high-level disinfectant solution to all parts of the endoscope to achieve effective liquid chemical sterilization or high-level disinfection of the endoscope and its parts. Now, we talked about water quality. It's even more important in the rinsing. Microbial quality of water used to rinse endoscopes is very important, especially with liquid chemical sterilant and high-level disinfectant processing. The quality of the water can vary greatly based on your facility and can actually recontaminate the processed endoscope. So you must follow the liquid chemical sterilant high-level disinfectant manufacturer's instructions for the quantity and quality of rinse water. You also need to know the number of rinses and the time required for each rinse in manual processes to reduce the chemical residue to a safe level. Follow the endoscope manufacturer's instructions and their recommended microbial quality requirement of the water to be used for rinsing. And again, you will find some recommendations in ST108. When you manually rinse, each rinse should be performed using fresh water. The container or sink used to perform the rinse should be clean. Don't use the same container or sink that was used to clean or disinfect the endoscope. Use critical water for the final rinse unless sterile water is specified by the manufacturer's instructions, and we do have some that are telling you to use sterile water for the final rinse. And follow the device manufacturer's written instructions for the specified rinse water quality. For automated high-level disinfection, use the quality testing for the AER that you're using. You should test this function at least weekly after any major repair or whenever you have a concern about the equipment's function. You should test the solution in the AER for the minimum recommended concentration or minimum effective concentration according to the instructions to make sure the solution is still strong enough to give you high-level disinfection. Repeat the cycle in the AER if the original cycle is interrupted because you can't be sure the liquid chemical sterilization or high-level disinfection of the device was successfully occurred. Endoscopes that have completed a high-level disinfection cycle in AER need additional drying of the internal channels with instrument air to remove moisture and also dried externally and stored to avoid contamination. Your AERs have a purge cycle that is not the same as drying. If the liquid chemical sterilant endoscope will be used in a critical application, such as in a surgical field, it should be used immediately after processing. It can also be used immediately in a semi-critical application. If it's not going to be used immediately, follow the instructions in the document for storage of high-level disinfected endoscopes. If a scope is left in the basin of an AER or liquid chemical sterilant system for any extended period of time of about an hour, the scope should be put back through the process before it is stored or used. And if an endoscope is transported to a patient room but not used, it must be processed again prior to the next patient use. Now, we said manual high-level disinfection of endoscopes is not recommended. If it is necessary because you have resource limitations, consult the endoscope manufacturer's instructions to determine compatibility of the device with the selected solution. So maybe your AER is out of service. Understand that the chemical that's used in your AER may not be a chemical that you can use for manual high-level disinfection. Use only those chemicals recommended by the endoscope manufacturer or that have been validated for use for both efficacy and compatibility and cleared by the FDA. Follow all of the instructions for use. And you may very well have a separate chemical, which means you'll have to bring it in, have all the testing to bring it in, do all the training and competencies on it. You should use a clean, dry container, use a timer to verify the soak time, and use a thermometer to verify the solution temperature recommended according to the high-level disinfectant manufacturer's IFU. And you should document the soak time, and you should document the temperature. Drying of endoscopes is very, very important. Endoscope channels should be dried for a minimum of 10 minutes each with pressure-regulated forced instrument air or a minimum of HEPA-filtered air. If you still have moisture present, extend the drying time until you don't see any moisture, and there is an Annex K for more information on drying verification. You should consult with the endoscope manufacturer's instruction for the maximum pressure so you don't damage the scope. You'll need a gauge on the instrument air to monitor the pressure. And never store endoscopes that are wet or before decontamination has been completed. Such storage will support the growth of microorganisms and biofilms. Dry the outside of the endoscope and removable parts, and yet again, you're going to use unused, clean, or sterile non-lensing cloths. You complete the drying after high-level disinfection to prevent the growth of gram-negative bacteria and other potential pathogens. The use of syringes or handheld compressed air guns to dry the channels is not recommended, even if their use is specified in the endoscope IFU. Remember, drying should be completed outside of the AER, even when the AER has a purge cycle or extended dry feature. A forced air nozzle or drying cabinet that's used to dry manually cleaned endoscopes could become contaminated with residual bioburden. This could be an issue if the forced air nozzle or drying cabinets are also used for drying or storing high-level disinfected endoscopes, so don't intermingle them. Consider using a separate forced air system and cabinets for high-level disinfected endoscopes and manually cleaned endoscopes before sterilization. The cabinets and nozzles used for manually cleaned endoscopes should be frequently cleaned and disinfected according to the IFU to reduce cross-contamination. And if you're going to do this, where you have both types of scopes in your cabinet, you should perform a risk assessment if the same drying implements are used both after high-level disinfection and after manual cleaning. Dry your endoscopes promptly after every reprocessing cycle. The scope should be dried whether the endoscope is intended for immediate patient use or for storage, and the exception is liquid chemically sterilized endoscopes that are used immediately. Alcohol is another issue that is controversial right now. There doesn't seem to be enough data to substantiate the continued use of it. We know that drying can be facilitated when we use a flush of 70 to 90% ethyl or isopropyl alcohol. But the issue is that isopropyl alcohol is considered a fixative. So if you have any microorganisms there, they're going to be fixed and difficult to remove. So if you want to continue to use alcohol, again, this would be something your multidisciplinary team should conduct a risk assessment. For terminal sterilization, with the infection risk that endoscopes present to the patient, sterilization is the preferred method of microbial inactivation and the only option for instruments to be used in critical uses, entering sterile body cavities, tissue, or vascular spaces. And that's the position of the FDA. Sterilization continues to be recommended for endoscopes. So certainly most of your operative scopes can be sterilized. Terminal sterilization is required for all endoscope accessories that penetrate the mucosa, such as biopsy forceps and sphincterotomes. And most endoscopes today require low-temperature sterilization, but we are seeing some that can be steam sterilized. Compatibility with low-temperature sterilization will vary with the endoscope make and model. Most flexible and semi-rigid endoscopes are not compatible with steam, but successfully sterilized endoscopes can provide an increased safety margin over high-level disinfected endoscopes. That's because when they're sterilized, they're completely dry, they're packaged, and they're patient-ready. They also have a tamper-evident seal that distinguishes used endoscopes from patient-ready, and the document has guidance on packaging and using several low-temperature sterilization methods. They're also I'm sorry, I have a second. This is stop here. This is a duplicate. So skip this one. Sterile endoscope sheets. Many manufacturers have sheets for endoscopes. For all sheets, after they're disposed of, the endoscope should be thoroughly cleaned and high-level disinfected or sterilized according to the IFU. Now, some IFUs recommend alternative processing instructions to liquid chemical sterilization when the sheath remains intact after the endoscope is used. For these endoscope and sheaths, the endoscope and sheath manufacturer's written instructions should be followed. If the processing instructions from the endoscope manufacturer and the endoscope sheath manufacturer are different or conflict, contact each manufacturer to resolve the issue. Now, there's two categories: sheaths that reduce the level of soiling and sheaths that are intended to prevent endoscope soiling. Endoscope sheaths can be used as an accessory device in conjunction with laryngoscopes, cystoscopes, and bronchoscopes, and the sheath is installed over the endoscope's insertion tube and might contain working channels where irrigation, suction, and accessories can be used. Now, the sheaths that are intended to reduce the level of soiling still have to be completely reprocessed. But if you have the ones that prevent soiling, you really should make sure and do an inspection after the procedure to make sure that there was no breach in the sheath. Otherwise, you will have to do complete reprocessing. We talked about the accessories. Make sure that all of the accessories, such as water bottles and tubing, are processed according to the IFU. And we talked about the valves, making sure that they were subjected to sterilization or according to the IFU. Any accessories that break the mucosal barrier should be cleaned according to the IFU and sterilized between each patient. You should not do high-level disinfection. Valves can be disinfected in an AER only if cleared for processing in an AER or be sterilized if in the IFU. Follow the AER manufacturer's instruction or the sterilization recommendations from the valve endosterilizer manufacturer, and only those accessories validated for processing in the specific AER should be processed within that AER. And I've seen bougies and dilators processed in AERs that did not have IFUs. So you should not put anything in an AER unless it's been validated for that process. And you should not be processing your bougies or dilators or anything else unless you're complying with those IFUs. Storage of endoscopes, liquid or high-level disinfectant or liquid. Store the endoscopes in a clean, well-ventilated, and dust-free area. Keep the endoscopes dry and prevent exposure to potentially hazardous microbial contamination. Store them to protect them from damage and contamination and according to the endoscope and storage cabinet IFU. Make sure the channels of your high-level disinfected endoscope are dry because you don't want bacteria to grow and for formation of biofilm. And if a drying cabinet is not used, dryness can be checked by using dryness indicators. As I mentioned, there's an annex that gives you a lot of guidance on that. For storage of high-level disinfected or liquid chemically sterilized endoscopes, you're going to store them vertically or horizontally. There is a cabinet that does allow you to store them horizontally. In a cabinet designed for storage in a way to allow circulation of air, and follow the endoscope manufacturer's instructions for pressure of airflow through the channels and the diameter of the endoscope coil. When they are stored vertically, the insertion tube should be as straight as possible with the distal tip hanging freely. Remove all valves and accessories before drying and during storage. Don't use tip protectors made of a material that can retain moisture, such as the sponge tip protectors, because this can create an environment favorable for microbial growth. Your tip protectors should not cover the opening of the tip of the scope, and tip protectors are meant to be single-use unless otherwise specified in the IFU. For reusable endoscope parts, these can be stored dry in a containment device designed and intended for this purpose. You should dry all of your detachable parts and devices and valves before they're placed in the storage cabinet, and they're dried according to the IFU. You need sufficient space between and around your endoscopes to prevent them hitting one another that can cause damage. All of your critical devices, such as your reprocessors and bronchoscopes, not used immediately, should be processed again before they are used. And if the endoscope has an angulation lock or a flexibility adjuster, it should be stored according to the IFU. Liquid chemically sterilized endoscopes intended to be used as critical devices should be used immediately after processing. And they can also be used immediately in semi-critical applications, so you don't want them sitting around in the processor. Storage. There's two types of storage cabinets for high-level disinfected process endoscopes: drying cabinets and conventional cabinets. Now, there's no clear consensus right now as to which type is best. However, a true drying cabinet has been shown in scientific studies to reduce the risk of retained moisture and microbial contamination. Endoscopes hung in HEPA-filtered storage cabinets that do not have drying capabilities need to make sure that the endoscope is completely dried prior to storage. Understand that a conventional cabinet, storage cabinet, will have the filtered air around the outside of the scope, but does not dry the channels. A drying cabinet will dry the channels. Both cabinets are designed to store endoscopes with or without channels in a controlled environment. Cabinets should be located in a secure location. It could be in the clean work room, but it cannot be in the procedure room, and it cannot be in a decontam room. This environment helps prevent contamination of process scopes. And when it's in a secure location, it's going to protect them from supplies that are vulnerable to misappropriation. In other words, if you have them in a controlled area, especially if you're in a facility where you have residents that can come in and out, they could be touching all of your scopes, and who knows what's happening to them. So you really want them in a secure area. Your storage cabinet should have doors and be located at least 3 feet from any sink. This will provide protection and reduces the potential for process-flexible endoscopes to be contaminated by splashes, and the cabinet should remain closed to protect the integrity of the scopes. You should visually inspect your cabinets and endoscopes to make sure they're clean when the endoscope is placed in the cabinet and when it's removed for patient use. An endoscope that's removed from a visibly dirty cabinet or is not dry should be processed before it is used. And storage cabinets should be cleaned and disinfected according to the manufacturer's instructions, or at least weekly and when visibly soiled, and make sure that cleaning is documented. Drying cabinets are closed cabinets designed for storage of flexible endoscopes that circulate HEPA-filtered or instrument air through the cabinet and each endoscope channel at continuous positive pressure. They provide very effective storage of your scopes to facilitate drying, decrease the potential for contamination, and provide protection for environmental contaminants. Internal and external surfaces of the endoscope are intermittently or continuously dried, suppressing microbial growth. They can be effective to limit bacterial growth during storage of potentially incompletely dried endoscopes, and you must follow the endoscope and the drying cabinet manufacturer's instructions. So this is a storage scope. This is a horizontal storage scope, and this is the drying cabinet that has the adapters that adapts to the channels so that you have the HEPA-filtered air going through all of the channels, making sure they stay dry and bacterial-free. There are closed cabinets, conventional drying cabinets. These are closed cabinets that circulate HEPA-filtered or instrument air through the cabinet, but do not include forced air through the channels. When drying cabinets are not available, you can use a conventional cabinet. They have to be cleaned according to the instructions. These cabinets with HEPA filtration should be used to store flexible endoscopes at a minimum. If you don't have at least HEPA-filtered air in your cabinet, you need to get one. When conventional cabinets are used, monitor if the channels have not been completely dried before placing them in the cabinet, so you should use drying verification tests, because remember, your conventional cabinet does not dry the internal channels. If indications that the scope is still wet, additional effort should be taken to ensure drying, and that could include more than 10 minutes of drying of each channel. Storage cabinets without any air, unless they're modified to provide drying or upgraded according with a third-party drying manufacturer's instructions and approved by the storage cabinet manufacturer, do not meet criteria as a drying cabinet. If your manual drying is used to verify the endoscope is dry, according to your healthcare's policy, make sure you follow Annex K to show you the manual drying process. You also need to identify the scopes that are in storage. They have to be identified by processing date, the name or names of the persons who performed the processing, and the expiration date, or what we call the hang time, based on your risk assessment. And here's an example of a high-level disinfected ID tag. The accepted maximum safe storage time really has not been defined. Many organizations have been looking at this. There is some data that says that the risk of contamination is reduced when storage is performed according to the endoscope and storage cabinet manufacturers. If bioburden is not eliminated prior to storage, it may become more resilient over time and continue to grow, especially if the scope is not completely dry. So again, you should do a risk assessment to determine the best hang time for your scopes. When we transport the process scopes, make sure you wash your hands. Make sure you put new non-latex gloves. Identify the endoscope is clean and protected from contamination and damage during transport. And if you're transporting it, unless it's being transported through a controlled connected corridor, the scope should be loosely coiled, placed in a clean, covered, solid protective container that's non-porous, leak-proof on its sides and bottom, puncture-resistant, and large enough to accommodate a single endoscope without the need to overcoil the insertion or light guide tubes. The container can be reusable, and it should be cleaned and disinfected between uses or a clean single-use container. The container or liner should be visibly identified as clean. You want to transport liquidly chemically sterilized endoscopes that could be used immediately in critical procedures in a closed processing container. If a closed container was not used, you should remove the endoscope using sterile gloves, transfer it into a sterile bin, and cover it with a sterile drape, and then in the room they would use aseptic technique to remove the device over to where they're going to use it. Quality control. You need a quality control program, and there's all the things we talked about should be included. Who's assigned to processing, your inventory of all of your scopes. That is required, a perpetual inventory. Procedures for the entire process. Procedures for cleaning verification tests or microbial surveillance. Verification of maintenance records of documenting that all manufacturers' recommendation for maintenance schedules are being performed for endoscopes and equipment. Verification that the scopes and accessories used in the facility and new equipment are compatible with your processing equipment and supplies. Verification and maintenance of records documenting that all recommended schedules and services for scopes are being used. Maintenance of records of the use of each scope, including the model, the serial number, and unique facility identifier. Records should document the patient upon whom the endoscope was used, the date and time of use, and the location of use. You should have a method to detect clusters or infections or suspected infections associated with endoscope procedures. And if you do suspect the cluster, infection prevention should get involved and do a complete case review and develop a process for segregating and saving devices suspected of being defective for investigative purposes, including the packaging and any information such as lot or serial numbers. You want to document each processing cycle regardless of the method used, the assigned lot or load number for the equipment that you use and the chemical, the operator of the equipment, the description of the specific contents in the lot or load, including the quantity of each item and the processing area, the name or unique patient identifier of the patient the endoscope was used, the procedure, the physician, and the serial number or other identification of the endoscope, and any microbial test of endoscopes or processing equipment. So what do? Obtain the document and see what you can change to comply with the standard now. Then determine what is achievable with minor costs to you and your facility, and work with your infection preventionists to implement the quality assurance protocols. Is your staff thoroughly trained or competencies verified initially and annually? You could do that now. Who performs the competencies? Do you have sufficient inventory of scopes and processing equipment and staffing to permit processing in full compliance with the IFUs now? And I did an article on staffing. Is there a quality monitoring system in effect to monitor compliance with IFUs and verify the cleaning of the scopes before high-level disinfection or sterilization? Keep current with changes in IFUs for processing your endoscopes. If any new scopes get clearance for sterilization, are they the scope manufacturer you're currently using, or would you have to switch endoscopes? Do you have the space for sterilization equipment? Because you probably would need a separate room for packaging and sterilization. And start working to comply with the recommendations in this document within your control. Remember, there's no specified time for implementation of this standard. It's anticipated the changes in scopes for sterilization could take 5 years or more, and I think it will take longer. Utilize your resources, such as the endoscope manufacturer, for training, and utilize your detergent and disinfectant manufacturers for training. When you're going to proceed with sterilization, carefully review the processes available. Make sure the process is validated for your specific make and models of scopes. Make sure your staff is thoroughly trained with competencies verified in the packaging and sterilization process. and make sure the packaging materials being considered are validated for the sterilization system you're considering. Remember, we're all in this together. Thought for the day: the colonoscopy isn't your eternal punishment, the prep is. Thank you for everything that you do. We really appreciate you.